going to talk about the little A today. Some of you may have guessed what it's about. Any guesses? Lipoprotein little A. Good. Can I start by asking you a question? How many of you know your LDL cholesterol levels? Your own LDL levels? Yeah, a few hands. So how many of you know your LP little a levels? Expected? I think you're in the right place and get ready to change your mind. So I have no disclosures, particularly no financial disclosure, or I haven't received any grants or possibly Sanofi. Just want to put it out there. So I'd like to start by showing you a picture of this man. This is a Maasai from Tanzania. As you can see, he's quite thin. He's a warrior, he exercises a lot. He eats meat, but the meat is sourced from animals who live under completely different conditions than the meat we eat. So I can start by saying that you might be wondering what the significance of this man is. I can start by saying that he's a very highly improbable patient to develop an acute myocardial infarction. You're less likely to see him in your clinics or in your hospital beds. Quite contrary to my patient, Mr. AR, he is 53-year-old Caucasian male, self-employed. He's got a background history of type 2 diabetes, fatty liver, depression, hyperlipidemia, and a strong family history of cardiovascular and cerebrovascular disease. He's an ex-smoker and has a BMI of 31.2. I don't think you could argue if I say that he's a highly likely patient to develop an acute myocardial infarction, and you're most likely to see him in your clinics or in the hospital. So Mr. AR's diabetes was diagnosed quite recently, in 2018. He is very well controlled on metformin, and he has a HbA1c of 56 millimoles per liter, which is pretty good. He has a history of depression, which is quite moderate to severe depression. He's had various different antidepressants being tried before, and now reasonably controlled on sertraline. His hyperlipidemia dates back to 2009, if not more. Most likely he had it for a long, long time. It's mixed with raised triglycerides and total cholesterol. He had some issues with anti-lipid lowering therapy, so atorvastatin and simvastatin were both tried, and his depression worsened, and he felt loopy. He had some diarrhea with acetamide, and he had a bit of rash with bezafibrate. So you can see some of the reasons why some of the drugs were discontinued were quite trivial, and the GP referred him for guidance on management of his dyslipidemia. He's otherwise fitting well. He does some steps, that's okay. So he developed some discomfort in his chest after walking 6,000 steps, which I sort of looked it up, and it's about 30 minutes on a treadmill, or about 2 to 2.5 miles. He also developed some aches and cramps in his calves around the same time, but doesn't appear to be clinically significant to think about intermittent claudication. On examination, he's classified as obese. He's got blood pressure 130 or 80. I particularly look for any evidence of pedicle stigmata for familial disease. So that would be looking for arcus cornealis. Actually, it's arcus cornealis rather than arcus senilis, because it occurs in young age in people with familial disease. Saphelasma, you might have seen some of them. Tempered Santamanta, and also evidence of any carotid bruit. So glad to say that everything was negative as the findings. He had normal cardiovascular examination. We also had a totally normal ECG. And he has palpable peripheral pulses in both feet with no evidence of neuropathy. This is his family history. That's Mr. AR there. As you can see, there's a strong family history of diabetes in his father, his mother, and also one of his older brothers. His grandfather had a sudden death at the age of 50. We don't know much about it. His father had a heart attack at the age of 60, but he lived till his 80s and eventually died of a prostate cancer. He has a younger brother who's on a statin. I'm waiting to get some more information on his lipid profile. And he has an older brother who had a ischemic stroke at the age of 50. So very strong family history there of cardiovascular and cerebrovascular disease, more likely to be atherosclerotic. He's married, he's got 3 boys aged 25, 23, and 21. So it's highly important to find out if he has familial disease, which has implications. So his labs, as he said, showing HbA1c in the nearly normal range for a type 2 diabetic, normal renal function, Normal thyroid function, particularly important if you're thinking about hyperlipidemia, as hypothyroidism can cause hyperlipidemia. Normal liver function and no evidence of any microvascular complications like myocardiuria or angiopathy. So this is his lipid profile. As you can see, it dates back quite a long time. I haven't got the results from 2009, but I can ensure that he's never had total cholesterol less than 7 millimoles per liter. And you can see his triglycerides are also quite significantly elevated throughout. He's got low HDL levels, and we've never been able to calculate his LDL. Particularly here, I'd like to point out that he had severe hypertriglyceridemia around 2018, which I think it coincides with the diagnosis of diabetes. So it's a very great illustration of how hyperglycemia can lead to hypertriglyceridemia. And you can see that it beautifully goes down his basal levels with the treatment of his diabetes. So based on his very long duration of hyperglycemia, and given the very strong family history, I did a lipoprotein little a level, and it came back as 99.3 milligram per deciliter, or 993 in our labs. It's given in milligram per liter. But because most of my talk is on Lp(a), and majority of the studies have given Lp(a) in milligram per deciliter, I think it's important to know that it's 99.3 milligram per deciliter. That's my usual practice. I'll go through that in a bit more detail about which patients do you check them and what's the testing criteria. So aim of my talk today is to talk about Lp(a) or lipoprotein (a). What's the pathophysiology? What is the cardiovascular risk that you could get with increased levels of Lp(a), and how to identify those high-risk patients? What are the measures we have in place to reduce the levels, and some future considerations? So what has been happening clinically from the 1980s is that the focus has always been on LDL, and we know that as clinicians we always look at patients' LDL. We try to reduce it as much as we can. We've been doing that for some time, but here you can see the epidemiological interest slowly diverted to HDL in the mid-2000s. They also introduced some drugs to raise the HDL levels, but failed to show any cardiovascular protection, so the interest gradually went down. But more recently, the focus has been redirected to the triglyceride-rich remnant cholesterols, and also this little guy, Lp(a), which is attracting a lot of attention, and it's actually on its way up. So we'll be seeing more and more trials and more information on this, so it's a good time to talk about it. So lipoprotein (a) is synthesized by the liver. It has a cholesterol-laden LDL-like particle, which is covalently bound to this large plasminogen-like lipoprotein called apolipoprotein A, which has an antifibrinolytic activity. The apo-A, this protein, apolipoprotein, has a kringle-like structure, so the kringle derived from the Danish pastry kringle, and particularly this version, the kringle4 type 2, makes this protein appear very large, so it's structurally quite different from LDL, and that's one of the mechanisms how it causes or increases your cardiovascular risk. So for those of you who don't remember all these lipoproteins, just to remind you that the lipoproteins are classified based on the density and size. So you have your high density, sort of smaller particle size HDL, low density lipoprotein LDL and Lp(a), which is similar, intermediate density lipoprotein, the very low density lipoprotein are the chylomicrons. So the IDL, the VLDL, and chylomicrons are the triglyceride-rich, or otherwise known as remnant cholesterol. The remnant cholesterol, along with LDL-C, makes it the non-HDL cholesterol, and sometimes they are interchangeably used as ApoB, but ApoB is a completely different entity, which you can measure separately. So in most of the labs, the majority of the labs I've come across, they do not measure LDL directly. They measure the LDL using this formula called the Friedewald formula, which includes total cholesterol, HDL, and triglycerides. So you can imagine that the calculated LDL-C is inaccurate if you have dyslipidemia, particularly if you have extremely high levels of triglycerides or very low levels of LDL. But again, I would like to draw your attention to this point here, that Lp(a) is not subtracted from LDL. So what you see in your labs as LDL for a patient includes the Lp(a). Lp(a) is composed of about 30 to 45% cholesterol. So if a patient has 100 milligram per mil of Lp(a), then your LDL will be overestimated by about 0.8 or 0.2 millimoles per liter. So that would explain some of the non-responders to statins. So some of the cardiologists might have noticed, if you are, or stroke physicians, if you start them on high dose high intensity statins, and you cannot get the LDL levels below that target, which you want, that most likely is due to this culprit, LDL delay. So that's one of the reasons you may want to measure it. So we're looking at the prevalence. This is the data from US laboratory database, so it's not an epidemiological cohort, but you can see that so there's a 20% prevalence at levels more than 60 milligrams per deciliter. There are about 64 million people in the United States, which is then globally estimated to be about 1.4 billion. So you can see it's a highly prevalent risk factor. And it's, you can argue that the prevalence is much more than what's the combined prevalence of triglycerides and elevated LDL. But this prevalent risk factor is not measured that frequently. It often goes underdiagnosed in patients, and hence the risk that is mediated by LDL delay is not that apparent because it's not measured. Again, showing a similar worldwide picture. Some of this is from epidemiological studies and observational studies. You can see there's a lot of prevalence in Africa. This is about 30%, and in South Asia about 25%. But the rest of the world, there is about 20% prevalence for LDL-related levels more than 50 milligrams per deciliter. But if you use the threshold of 30 milligrams per deciliter, then the estimate is about 2 billion, more than 2 billion in the world. So I'll be talking a lot about the Copenhagen German population study, which is one of the biggest of its kind. It's a large epidemiological prospective cohort study. Some of you may have seen it. It's been cited quite a lot in lipidology and also in other conditions. So it's a study that started recruiting in 2003. They recruited about 100,000 individuals who are representatives of the German population, and they collected data on the genotypic and phenotypic characteristics with regard to a wide range of medical problems, not just dyslipidemia or cardiovascular disease, but also on chronic conditions like diabetes, COPD, hypertension, etc. And this study completed, so there's a decade, more than a decade of follow-up. I think they completed the study in 2015. So there's quite a lot of data on originating from the study. So you can see that this is a graph which shows the fraction of the population, showing a skewed distribution of the population towards really high levels of LDL-delay. So that some of them reaching really high levels, 200. So Mr. AR will be right here, so the other 99.3. And they found that about 20% of the Caucasians had levels more than 50 milligrams per deciliter. What they also interestingly found is that about 80 to 90% of this is genetically determined. So there is a genetic risk factor. So some of these levels are, or 90% of it's inherited, which is unfortunate. So we cannot modify it with your diet or exercise or other measures. And this graph interestingly shows that the higher the number of clinical type 2 repeats, the lower the concentration of LDL-delay, which would explain some of the ethnic variations in the levels as well. So concentrations differ with different ethnicities, as shown in this one, in this graph. So we give inequitable range of lipoprotein delay in milligram per deciliter, showing lower levels in whites, Chinese, and Japanese, and higher levels in Hispanics and blacks. The Indians are somewhere between Hispanics and blacks. I couldn't find a lot of information in the New Zealand registry about this, but this is one study that was done by Professor Vicky Cameron at the University of Otago, and they looked at gene markers for LDL-delay in Maori, Pacific Island, and European adults. What they found is a small number of people, and they measured their LDL-delay levels and sequencing Kringle4 type 2. So the results showed that the overall levels were significantly different between all the three ethnic groups, with New Zealand Europeans tending to be higher than Maori and Pacific Island groups, which is quite interesting given the higher risk of cardiovascular disease in that group of population. And there was no difference between Maori and Pacific Island participants in the levels as well. So moving on to the pathophysiology. LDL-delay developed twice in evolution. So it must be a really important protein for something to develop twice in evolution. There might be some beneficial effect which prolonged the survival. It developed its first version in the hedgehog, and then a few years later, many years later, another evolution which developed another version in monkeys and apes, which is the same form that then carried on to the humans. So the hypothesis is that because of the antifibrinolytic activity of the ApoA kringle, it could potentially have resulted or helped us with wound healing physiologically. Therefore, pathophysiologically, it could lead to thrombosis. Thrombosis can lead to aneurysm and atherosclerotic stenosis, and atherosclerosis eventually. The pathogenic mechanisms of LDL-delay is being derived from a lot of animal studies and in vitro studies showing an effect which is pro-atherogenic, pro-inflammatory and pro-thrombotic, so it's triple whammy. So we have your LDL, which is mostly pro-atherogenic, triglycerides, mostly pro-inflammatory, and on top of that we have LP-little, which has got all these effects plus pro-thrombotic. So this, the key observation that you can derive from this graph is that all these genetic variants, which are called SNPs, they're all on a linear scale. So that means the lower the concentration, the lower the risk of coronary artery disease. We can see that's one gene which stands out completely different, and that's your LP-little gene. And the risk is much higher than that can be explained by the median cholesterol content. So there must be some other mechanism which is now poorly understood, the way it causes cardiovascular disease. So the hypothesis is that physiologically at a young age, LP-little helps with wound healing, particularly important in childbirth, some infectious diseases we had decades ago, which increases your risk of bleeding, and also helps with injuries due to wartime, etc. for survival. And then pathologically now in old age results in aortic stenosis, atherosclerotic stenosis, and myocardial infarction. So are you ready to test out those hypotheses? So I'll show you some quick studies. So this is again from the Copenhagen General Population Study and Copenhagen City Heart Study, which is pretty much a similarly conducted study at the same time, showing that the risk estimates are much higher in myocardial infarction and also in aortic stenosis, almost sort of similar results, compared to venous thromboembolism, where there is really nothing. So clearly, LP-little has a function in the arterial circulation, where there is a huge turbulent flow and the blood pressure is quite high, etc. So when it comes to myocardial infarction, the hazard ratio is going higher and higher on a continuous scale as the levels go up to 2.4 folds, but this is at 100 milligrams per deciliter. So the emerging risk factors collaboration published this study in JAMA in 2009 actually, so that's a long time ago. And it's a meta-analysis from 120,000 participants from about 36 prospective studies, showing a curvilinear association of rising levels of LP-little with risk of non-fatal MI and coronary death, and again similar results with ischemic stroke. This is an interesting paper, which I think the key point here is they classified people into FH and no FH, and they measure the LP-little. And what it shows here is you can see the risk going up with high levels, but what it shows here is those people who had FH with raised levels of LP-little had a higher incidence of myocardial infarction compared to those who had levels less than 50 milligrams per deciliter. So this is again from the Copenhagen General Population Study, which shows a clear stepwise increase in cumulative incidence of myocardial infarction with levels up to more than 120 milligrams per deciliter of LP-little. Similar data in men and women, there's no difference. So the conclusion is that the hazard ratio is 3-fold risk of MI and 2-fold risk of ischemic heart disease with levels more than 90th percentile of predicted. So when it comes to aortic stenosis, you can see there's up to a 3-fold increased risk with levels more than 124 compared to 3, showing a clear linear association. When it comes to heart failure, there's about 1.7-fold increased risk with levels more than 99 percentile predicted. When they did a mediation analysis on that, they found that most of this is mediated by MI or aortic stenosis rather than causal effects. Nonetheless, they gave a population attributable risk of 9%, meaning that in theory, if you effectively lower your LP-little concentrations, you could reduce the risk of heart failure by 9% in these people. Again, all-cause mortality is not very well described, but you can see that in 70,000 individuals with an event rate of 10,000 deaths, as soon as your levels go up above 50 to 60 milligrams per deciliter, your all-cause mortality rises. This is also a pooled data from the Copenhagen General Population Study. This is a very interesting graph, clearly showing a higher risk of major adverse cardiovascular events with higher levels of LP-little. But again, what I'd like to show you here is that if you reduce the levels of LP-little from 100 to 50, that's by 50 milligrams per deciliter, then you could, over a short period of time, so that's short term for 5 years, then you could effectively reduce your MACE by 20%, particularly important in secondary prevention settings. So that's the sort of lowering we're looking at. So by 50 milligrams per deciliter, short term, 5 years, you could benefit from cardiovascular protection. So who to test? So this is the European Atherosclerotic Society guidelines. It is quite similar to the American Heart Association guidelines. You will see the same guidelines everywhere. This is the most recent update, and they've given a class 2A evidence for it. So what they're suggesting is Lp(a) measurement should be considered at least once in each adult person's lifetime to identify those with very high inherited levels who may have a lifetime risk of atherosclerotic cardiovascular disease equivalent to the risk associated with heterozygous FH. So they're asking everybody to screen people for heterozygous FH by doing their Lp(a) levels. They also suggest that it should be considered in selected patients with a family history of premature cardiovascular disease and for reclassification of people who are borderline risk between moderate and high risk. So that my patient would probably come under this category. And to summarize, as a minimum, you should consider doing Lp(a) levels in individuals with premature cardiovascular disease, with family history of premature cardiovascular disease, and or high levels of Lp(a), FH patients, which is familial hypercholesterolemia, recurrent cardiovascular disease despite optimal lipid lowering treatment. So those are the patients we are going to see in our cardiovascular clinics, stroke clinics, and also in our cardiology or stroke beds with various different cardiovascular events, including heart failure. And if you have a more than or equal to 5% 10-year cardiovascular risk, which comes with the risk engines, which I'll talk about in a bit. So what are the measures we have in place for lowering Lp(a)? Unfortunately, not much. So statins have zero effect, or in fact, some studies have shown a slight increase in Lp(a) levels with statins, but not clinically significant. Niacin, CETP inhibitors, and ApoB antisense are players who have come and gone. They've been all withdrawn due to their side effects, but did achieve about 25 to 30% reduction. ApoB antisense at severe hepatotoxicity, so that's all gone. The current player in the field is a PCSK9 inhibitor, which has shown 25 to 30% reduction in Lp(a) levels in studies. I'll talk about that in a bit. Apheresis is used quite a lot, particularly in countries like Germany and the rest of Europe. We have a center in Christchurch where they do it, and has shown some real good benefits with removal of Lp(a), and trials have shown some benefit. And the future in the field, future plan in the field is ApoA antisense, which I'll touch upon as well. So PCSK9 inhibitors been around for some time. This is a study on FH patients, which is published in the European Heart Journal in 2017, clearly showing that an added benefit, so compared to statins alone, adding a PCSK9 inhibitor will reduce your Lp(a) levels by 30%. So these are the two big trials, which are the hot topics of discussion in the lipid world these days. This slide doesn't do any justice to these trials. They need their own time and a journal club presentation at some point, but again, a snapshot. The Furia used evolocumab and Odyssey used alirocumab, both are PCSK9 inhibitors, and they've shown an absolute difference in LDL cholesterol at 12 months by 56 milligram per deciliter and 48 milligram per deciliter. That's about 50 to 60% reduction. And they've also shown excellent outcomes with their primary endpoints and triple composite endpoints. A 20% related reduction in risk reduction in MACE, with reduction in MI, stroke, and coronary revascularization. And obesity has shown some benefit with all-cause mortality as well. But again, I'd like to draw your attention to the Lp(a) subgroup analysis here. Basically, they measured Lp(a) at baseline, week 12 and week 58. I'm not going to go into the details of this, but essentially, for people with baseline Lp(a) levels, about the median had a hazard ratio of cardiovascular death, MI, stroke with evolocumab versus placebo, which means that of 0.76, which means that's a reduction of 2.8%, and the number needed to treat of 36, which is slightly different from for those who had levels below the median. So essentially, the conclusion is that the risk was lower in patients who achieved a combined reduction of Lp(a) and LDL compared to LDL alone. So clearly showing a benefit with Lp(a) lowering, and those who started with higher levels of Lp(a) had better or greater absolute benefit. So what do we have for the future? The PCSK9 inhibitor Praluent is available here in New Zealand, but it's not funded. So for us, that will be the future, to get it funded for at least our FH patients, or those who are clinically classified as familial hypercholesterolemia, for example, my patient Mr. AR will benefit from it. It costs about $850 a month, so that's a fortnightly subcutaneous injection, so you have 2 disposable pens, and that's, as I said, trying to get it funded for at least 70 critical patients will be what we can look forward to. But the future really in the rest of the world or in the scientific community is probably the ApoA antisense therapy, which will be something to look forward to. So ApoA antisense inhibits the ApoA criminal protein synthesis, which then inhibits the release of Lp(a). And these are the studies which has shown up to 90% reduction in Lp(a) levels to levels we've never seen before. And you can see a dose-dependent reduction with 10 milligrams, 20 milligrams, 40 milligrams. So that's still, and the side effect profile is looking good. I mean, this is an ongoing phase trials which will be coming along. So coming back to Mr. AR, what do we think is Mr. AR's cardiovascular risk? I'm sure we all use different risk engines. I'm sure you will have a favorite of your own. But I just wanted to give you a few that I've done with Mr. AR's cardiovascular risk. So this is the NZSSD score, which is a very good score for people with diabetes. And this is probably the only score which allows you to scroll down the ethnicity and change to Maori. So if you have a Maori patient, this is particularly useful. It's mostly, as you can see, this is mostly based on diabetes. So it's a lot of questions about diabetes and diabetes complications. And it gave me 11.6% 5-day cardiovascular risk for Mr. AR. This is a Framingham risk score, which I'm sure most of you have used, or probably using at the moment. Again, very crude data that hardly required any data, and gave me a 16.7 10-year cardiovascular risk of MI or death. And I did the QRIS-3 score, which is something which I'm very familiar with using in the UK. And I've seen it developing from the QRIS-1 to QRIS-2 to QRIS-3, so I know what changes they've made to the score. And you can see that a lot of other variables they ask for example, migraines, rheumatoid arthritis, lupus, severe mental illness, antipsychotic medications, etc., etc. And he did qualify for one of them. But I'm quite surprised that he gave me quite a high score, 39.1% 10-year cardiovascular risk, which I'm tempted to believe because of the family history and in the long duration of his cholesterol levels, the Lp(a) levels. And it's a useful tool to show to the patient. They understand it better if you show them that picture. They usually open their eyes and listen to you a bit better. So he's had, well, that's the score I got. What I wanted to really show you is that huge amount of variations that you get with these risk engines. And there is always a 10 to 15% difference either way. Some of them overestimate your risk, some of them underestimate your risk. But none of these scores have actually asked you for Lp(a) levels or your CT calcium score or ApoB levels or anything like that. So what studies have shown is that if you put the Lp(a) levels into these equations, about 40% of your patients will be reclassified into higher or lower levels. Mostly lower levels because most of them will have lower levels of Lp(a). So it matters at a clinical level to measure Lp(a). So in order to sort of accurately risk estimate your patients, particularly if you have a patient who is at borderline risk, you can push them up to higher or lower risk based on your Lp(a) levels. So I had a discussion with Mr. AR about pharmacotherapy. I have one more statin left, which is a pravastatin, or he can choose the expensive twice-weekly, fortnightly injections with PCSK9 inhibitors. His choice was very clear. He said, "I'll take the pill, doctor." So I got him on. So just to remind you that simvastatin and atorvastatin are metabolized by cytochrome P450, so they are more prone to medicine interactions, but clinically relevant interactions are rare, especially with antidepressants. But he did have a true worsening of his depression. But pravastatin, lucky for him, maybe lucky for me, it doesn't cause so much of interactions because it's not metabolized by CYP. And as I said, it's the only statin which I can prescribe. Same thing with rosuvastatin, which is one of my favorites as well, as a two-go statin. So this is my treatment plan for Mr. AR. So I'm seriously thinking about getting a genetic testing for familial hypercholesterolemia or familial combined hyperlipidemia, because clinically he has shown some evidence pointing to that direction. I started him on aspirin. Again, it's a controversial area. The studies have shown that if they have familial component to their hypercholesterolemia, then you can delay the progression to thrombosis, etc., by giving them aspirin. So until I get the results back, I will keep him on aspirin, and also it's relevant in people who have higher Lp(a) levels. I started him on EPA for his hypertriglyceridemia because I'm not going to start him on a fibrate at this stage. And if you are ever going to start someone on EPA for hypertriglyceridemia, the dose is 2 grams twice daily. I started him on pravastatin 10 milligrams once weekly, which is the lowest effective dose I could go down to. It has shown some benefits, so I think it's a good start. And I always start anyone on primary prevention at the lowest effective dose and slowly up titrating. I'm pleased to say that he's actually done it quite well, and he's doing it once every 2 days or 3 days without worsening his depression. So, and I advise the GP to consider increasing the dose of sertraline or maybe adding in a second agent if his depression worsens. Then lots and lots of lifestyle advice, last but not the least, improving on his exercise and also trying maybe a particular diet like Mediterranean diet, for example, that might benefit him. So I did send him to a dietitian for some input on that. And I requested a carotid Doppler, which does not show any evidence of stenosis, which is good, and a CT calcium score. I haven't got a formal report on that yet, but Dr. Tang thinks it's negative and probably got no calcium in it. So that's really helpful again in this particular case. So I can relax a little bit on his lipid lowering. I don't have to now proactively seek PCSK9 inhibitors funding for this man to lower his Lp(a) levels, given the fact that he may have a 0 CT calcium score. So that's a hot topic again, the non-invasive cardiovascular risk assessment of the asymptomatic diabetic patient with carotid interval thickness, coronary artery calcium score, and CT angiography. The bottom line is it does make a difference, and it does help to understand the risk in these patients with type 2 diabetes, especially if they've got a high score. For example, if they have more than 200 Agatston score, it helps to risk estimate them better way. So this is a website, a bit of like foundation website for those those patients who need to check on resources, and you can guide them to this website. And as with anything else in this world these days, I'm sure higher levels of Lp(a) will increase the risk of COVID-19, and you've got some resources there as well for you to have a look at. So I have some key points. Lp(a) measurement should be offered by all laboratories. We do have it, we do send it to Canterbury so we can get it done. The results usually takes about a couple of weeks to get back. We must consider measuring it at least once in a person's lifetime. The levels doesn't seem to change, they remain constant and stable throughout a person's lifetime, so just measuring it once will do. But if you are using drugs to actively lower the levels, then you may need to remeasure them at a certain stage. Lp(a) is co-measured with LDL-C, so if you have a patient you think is not responding to statins and they're still having multiple events, that's one of the reasons to measure it. This is the most important point I'd like to draw your attention to, is that high levels should usually prompt a more aggressive approach to other risk factors. So if you have other clinically apparent risk factors, for example, if the patient's a smoker, or if you have a patient with a HbA1c of more than 100, or hypertensive, obese, etc., I think it's crucial to look into those risk factors and try to modify them. In those particular cases, measuring Lp(a) adds very little value, if that makes any sense, yeah? So there's no point in having a knee-jerk reaction to measure Lp(a) for everyone if there are other risk factors to look at. So this, getting almost finished, this is my final take-home point. This is how I see these 4 lipoproteins today and how they've got something to do with cardiovascular disease. People used to say, or used to think, that HDL is an anti-atherogenic or good cholesterol, somehow miraculously takes away all the cholesterol from your arterioles and back to your liver. There is no human evidence to support this, so this remains a hypothesis until further evidence. I mean, we've got about decades of evidence now to say that it's not applicable in any way clinically. Among the other 3 lipoproteins, LDL is pro-atherogenic, results in stable plaques. The triglyceride-rich remnants are more pro-inflammatory, which makes the plaques vulnerable to rupture and then causes thrombosis. And then you have the genetically driven Lp(a), which makes your thrombosis grow faster and faster and makes that event of MI more pronounced. So my final slide is from the Clint Eastwood movie, The Good, the Bad, and the Ugly. HDL, which used to be called good cholesterol, I think we should call it from now on innocent cholesterol rather. LDL is still by far the bad. The remnant-rich triglyceride, the triglyceride-rich remnants are the ugly ones, which are worse than the bad ones, and you have your Lp(a), which I think is equally as bad as the remnants. With that, I finish my talk and take questions.
Thank you very much. That was really very interesting. In the study in Copenhagen, you mentioned that obviously there was a good correlation between the level of LPA and increasing mitochondrial infarction. What about the other risk factor that you mentioned in your patient, for instance, a calcium scan or other factors? Was that considered in that study or not?
In that study, no, they didn't. It was just a cohort, epidemiological cohort study. They didn't do any particular investigations. The reason why I did CT calcium score is based on his family history. So clearly, if they had a family history which is suggestive of a familial disease, one has to assume that he had high cholesterol from the age of 6. So if he had that, then along with his Lp(a) levels, he's more prone to thrombosis and most likely calcium. So I have seen so many patients with Agassi score more than 200 in these situations as well. So lucky for him, I think his calcium is negative. I couldn't see anything on the CT, but I'm waiting for a formal report. But it looks like he's got 0 calcium. Yeah, it's an additional test.
He had 3 boys, and they're now in their 20s, and obviously you'd be screening them as well.
Yeah.
What age would you start screening somebody
for FH? Yeah. So I think the question is whether he has whether there is a likelihood of homozygous FH or heterozygous FH. Now that his children are in their 20s, it's less likely that they have homozygous FH because they may usually present before the age of 20 with heart disease and heart attacks. The screening schedule is usually starting at the age of 6 years. 6 to 10 years is the usual time for starting the screening. So yes, they will qualify for screening at this age. Yeah, but most likely he has heterozygous FH. Yeah.
Sorry, I may have missed the beginning. Is this test done in Rome, or you have to send it to Christchurch, or?
Yeah. So it goes to Canterbury. Yeah. It costs about $16, so it's not that expensive. Want to do it?
And does it require specialists to request it?
So it goes along with the lipid profile. Yeah. Same sample, they sent it to the labs as well.
So you have to mention.
You have to specifically ask for it. Yeah. I mean, I didn't mention that I've actually done quite a few other tests which are still pending. So I usually do an ApoA, ApoB, and an ApoE, which also is helpful for risk estimating these patients. Again, it doesn't apply to everyone. Didn't want to make it too complicated.
Probably a lot of these patients are going to be in primary care. So where's the primary care guidelines at in terms of, because most of the patients will be identified out there and would appropriately be exposed to this. And where primary care is at in terms of awareness / testing?
Yeah, I think awareness certainly needs to be there. And when I looked up for prevalence of FH in New Zealand, there's absolutely no data. We don't know the prevalence of FH in New Zealand, and that indicates that there is an urgent need for screening these patients. And I don't know how many. I mean, that's the reason for the talk is to give awareness to the junior doctors as well, to have a think about FH as a potential cause for some of these recurrent events in young people who present with MI. I mean, all you can quickly do is to check their eyes, looking for arcus cornealis, look for xanthelasmas, and that's something which you can easily do. So awareness is definitely something which needs to improve, and some surveys to looking at identifying these patients will be really helpful. Yeah, but that's the guidelines for everyone. So that's the EAS guidelines is for primary care as well, to screen these people. Yeah.
Do we have a lipid clinic here? Can we send the patient to you, for instance, with the high cholesterol?
Yeah, I mean, me and Dr. Mishra, we both do lipids. We don't have a dedicated clinic to do them. I think that's again because of the lack of awareness. We are not getting many patients. And some of them, for example, this GP is more concerned about what next rather than his cardiovascular risk when he refer this patient. So clearly the focus is different. And we pick up a few genetic courses, and there was another man who had an ApoE abnormality in his triglycerides. So there are lots of things that we pick up. So, but most of it is based on guidelines. So if you follow the 2019 guidelines, or if you can follow the AHA, you will see exactly the same things. So, you know, we are happy to see, I'm sure Dr. Mishra will agree, we're happy to see any patients with liver problems. Yeah.
You're surprised to see the calcium score normal on the creatinine because it kind of goes against it, right?
I mean, it's not surprising sometimes to see no calcium in the CT. That doesn't mean he hasn't got atherosclerosis. It's just that his calcium is negative. I'm not an expert in CT calcium scores. I think you had a grand round very recently on that. I'm sure the cardiologist will have a different guideline, a different view on that. Yeah.
Will it affect the treatment with aspirin for that patient?
What's the question, sorry?
The calcium, will it affect that you will stop the aspirin treatment or?
No, I think the aspirin is not related completely to the CT calcium scores. The studies have mainly looked at the cumulative effect of cholesterol and Lp(a) on these patients with genetic problems. So it's not entirely related to the calcium score. So I'd like to wait for the genetic test to confirm that he's negative before I stop it. I think he will benefit from that because now the fact that he's on a very small dose of statins, I can't give him any more than what he's taking, plus his triglycerides are still quite high, and we can't give him anything to lower the Lp(a) levels. I think that's sort of a protective mechanism. As I said, different people have different views on aspirins, but the guidelines clearly say that if you have Lp(a) levels more than 70, then it's a good idea to consider aspirin in those cases.
I think the point you made about the other risk factors often gets overlooked by me, for example. So that's a good point. I would stress on that because LPA alone will not make a difference. We need to get it in context of everything.
Yeah, absolutely. So for him, his diabetes is well controlled, his hypertension is well controlled, he's doing something about his weight. So there's nothing else that you can, there is no other risk factor that I can modify. So that's one of the reasons why I probably did it.
We often ignore as well the triglyceride levels, and you made mention of that, and I mean there's a lot of other reasons like alcohol and that can cause
Diabetes.
high triglyceride levels. But you prescribed him EPA. Is that actually on the fund, is it, or is it you just say you'll go to the chemist and?
Yes, I think it's cheaper if you can get it from a pharmacy, from the shops somewhere.
Right.
Yeah.
And don't worry about what's the other part of the DHA or there's EPA.
There are a few. I think I tend to use EPA, which is what's been studied and what's shown some effect on triglycerides. So if you want to give, I think it's shown about 20 to 30% reduction in triglycerides with that dose, the 2 gram twice daily, and it's recommended as well by the guidelines. So it's one thing which might help.
Right. And you repeat the measurement in what, 6 or 8 weeks?
Ideally about 8 weeks. I usually do because I started on statin. I will do a liver function and another check on 4 weeks, but 6 to 8 weeks is right.
Another question. I have seen recently a patient, a 40-year-old, previous alcoholic, had steatohepatitis hepatitis with the fatty liver, severe fatty liver disease. But he came with a cholesterol of something like 26.
Total cholesterol or
Total
triglyceride?
cholesterol 26, and triglyceride or something 46 or something.
Right.
The side was quite stunned really, because we see a lot of alcoholic liver and fatty liver, but we never see something with that level. This, I was looking for a lipid clinic to actually send a special. That's why I asked you. Anyway, he's on some medication and slightly reduced the cholesterol. So you think?
Yes.
His ferritin was also very high, 4,000.
And he's a diabetic?
He's not diabetic, he's quite thin. But I think that must have an additional risk factor.
I think he probably has something, again, familial like hyperchylomicronemia or something like that. So he's at very high risk of pancreatitis. Because once your triglycerides goes above 10, you're high risk of pancreatitis. So he should definitely be on a statin to start off with. And EPA might also help while he's waiting to, I mean, you can, I can't say that you want to refer, but that's, someone who would like to see in the clinics and might need a genetic test. Yeah.
Another point is to cut down the fat content less than 30-40 grams
Yeah.
a day, which is most difficult, but that's the main point.
Yes, a low carb, low fat diet is what probably you will benefit from. It's mostly carbohydrates which surprisingly causes some triglycerides.
Low carb, low fat, low good. No.
Just nothing edible, nothing tasty. No alcohol.
Right, thank you.